Hello everyone, today the topic which we guys gonna study is adrenal crisis, also called as Addisonian crisis. The adrenal crisis is a severe adrenal cortical insufficiency, mean when the level of the adrenal cortical hormone drop rapidly and acutely. It is called as adrenal crisis. It is characterized by two things. The first one is a circulatory shock and the second one is a severe hypotension. Now a question arises that what caused the adrenal crisis? The adrenal crisis is caused by two factors. The first one is that it occur secondary to some adrenal pathology, and the second one is that it can precipitate secondary to acute stressor. By the adrenal pathology, we mean that there is something going wrong with adrenal gland which will lead to atrophy or the destruction of an adrenal gland. It can occur due to variety of causes. The first one is an Addison disease. When a patient develops Addison disease or the chronic primary adrenal insufficiency and the patient is not aware of a disease, so the adrenal crisis will be the initial presentation of the Addison disease. The second one is when the patient use a chronic steroid for some other disease. So when patient stop that steroid, the patient can present with an adrenal crisis. How this exogenous glucocorticoid is leading to adrenal crisis? Remember that when a patient is using exogenous glucocorticoid, it will stop or it will interfere with HPA axis. So the normal production system of the cortisol from the adrenal gland is suppressed under the influence of exogenous glucocorticoid. So when we stop the exogenous glucocorticoid, the normal HPA axis is not functional. So the adrenal gland will fail to produce cortisol. So the patient will present with an adrenal crisis. The third one is a bilateral adrenal hemorrhage. Mean when a patient develop a meningococcal septicemia. So in this condition, the patient have a bilateral adrenal hemorrhage which will lead to the destruction of the adrenal gland. So the adrenal gland will fail to produce a cortisol and the patient present with an adrenal crisis. So it was all about the adrenal pathology which will lead to adrenal crisis. Now come toward the acute stressor. By the acute stressor, we mean that when a patient present with surgery, trauma or any infection, in this condition, normally there is a high requirement of a cortisol. So when a patient have fail to increase the cortisol level, the patient can present with an adrenal crisis. What will be the clinical feature of a patient who present with adrenal crisis? The patient will present with a muscle cramp, nausea, vomiting, diarrhea, acute abdomen, collapse and unconsciousness. On lab finding, we will see hyponatremia, hyperkalemia and sometimes hypoglycemia and hypercalcemia. So there are two hyper condition and the two hypo condition. The hypo include hyponatremia and hypoglycemia and the hyper include the hyperkalemia and the hypercalcemia. Now we will talk about the management of adrenal crisis. It is very important and we will spare some good amount of time to understand the management of adrenal crisis. When a patient present with adrenal crisis, blood is taken to measure the serum cortisol, glucose and electrolyte. When we check the blood test, there will be a three problem. The first one is the shortage of salt, second one is the shortage of sugar and the third one is the shortage of steroid. Remember by a 3S, salt, sugar and steroid. To manage these problems, the first line intervention is to give IV fluid in the form of normal saline. Usually 1 liter of a normal saline is given in about 30 to 60 minutes. But remember that after this the patient may need several more liters of a normal saline. It depends on a patient condition. After replacing IV fluid, the second step is to replace the glucocorticoid. For that we use hydrocortisone. The hydrocortisone is adjusted in very peculiar manner in adrenal crisis. Initially, when a patient presents with adrenal crisis, we give an IV hydrocortisone 100 mg stat. After that, we give 100 mg IM hydrocortisol in over the time period of 24 hours. Mean that after every 6 hours, we will give IM hydrocortisone till a patient is stable and taken by mouth. When a patient is stable and is able to start eating things by mouth, so we will replace the IM hydrocortisone with oral steroid. The oral steroid is started initially at a dose of about 20 mg 8 hourly. After that we will reduce the dose and we will adjust it, like we will have to give that 20 to 30 mg in divided dose. When we patients start feeling more better, at that point we will replace the requirement of glucocorticoid, because there is a deficiency of a glucocorticoid which lead to adrenal crisis. So we will adjust the glucocorticoid level, and the patient will take the lifelong glucocorticoid. Mean that the original replacement therapy for the glucocorticoid replacement should be given. After hydrocortisone, the next thing which you have to manage in adrenal crisis is hypoglycemia and hyperkalemia. The hypoglycemia is corrected with 10% IV glucose. For hyperkalemia, the volume replacement is sufficient. No extra treatment is usually required. The volume replacement will treat the hyperkalemia, but occasionally it may require a certain therapy. So it was all about the management of adrenal crisis. The last thing which I have to discuss is that when a patient have adrenal crisis secondary to certain precipitating factor, so for that we have to treat the underlying cause. At last, I will discuss two concepts which is very important to understand. The first one is that when a patient with adrenal crisis present with severe hyponatremia, mean when the level of hyponatremia is less than 125 millimole per liter, we treat the hyponatremia with normal saline. Why we are not using hypertonic saline? We are not using hypertonic saline because it will raise the sodium level greater than 10 millimole per liter per day. So when the sodium is increased with this higher rate, it can cause a central pontine demyelinosis, which is a demyelinating disease. So it is very troublesome. So to prevent this disease, we use a normal saline, and it will slowly and gradually increase the sodium level. The second concept is that in adrenal crisis, why we are not using the mineralocorticoid? Because the mineralocorticoid such as the fludrocortisone is unnecessary. In adrenal crisis, the cortisol, the glucocorticoid such as the hydrocortisone also play a role of a mineralocorticoid. So it is not necessary to start a mineralocorticoid in management of adrenal crisis. But the mineralocorticoid can be started later on. But in adrenal crisis, we just replace a glucocorticoid. We do not use mineralocorticoid. So it was all about the adrenal crisis, how it causes, what will be the clinical feature, and how we will manage the adrenal crisis. If there is still any question, you guys can ask, and stay tuned for more update.